Thank you, everybody, for tuning in to our Season 2, Episode 2 of ZollCenter. We are joined today by an absolutely stellar cast. Myself and Mike Me will be your co-hosts. And today, our experts, we have heart failure expert Dr. Pablo Quintero with us, along with Dr. Coco Fresh, who will be walking us through some cardiac imaging today. And last but not least, Dr. Jason Spolsky from the Hematology Oncology Department will be joining us as well. So without further ado, let's get into our case. We are talking about a 63-year-old, relatively healthy man who was referred to the Cardiac Direct Access Unit by his PCP for about 1 week of progressively worsening shortness of breath on exertion and when laying flat. He also noted some new leg swelling that had started in his ankles initially and now up to his shins over the last 5 days, not improved with elevation of his legs. At this time, he also denied any chest pain, any fainting, any loss of consciousness, or any palpitations at all. He also points to numerous bruises on his arms, noting that this too is new for him over the last couple of months. On past medical history, he does have a remote history of alcohol use disorder, but he's been abstinent since 1990. He also has ADHD. Medication-wise, he doesn't take much. Methylphenidate, hydrochloride 20 TID, and trazodone 150 at night. So he lives with his family and works as supervisor for a construction company. He does smoke about half a pack a day since age 30, puts him at around 15 pack years without any recreational drug use. Of note, his father is deceased. He also had alcohol use disorder and had a history of congestive heart failure. Not too much information on that, however. As far as his mother, she is living and does have CAD with a cabbage. Now, on examining the patient, we noticed that he was afebrile, normotensive with a heart rate of around 99, and he's sounding well in room air. And I want to highlight the main points here. So he had a JVP elevated around 14 centimeters on 45-degree angle, no carotid bruit, and we also noticed that he's got crackles at bases bilaterally on long auscultation. Looking at his extremities, you see that he's got 2+ pitting edema in both lower extremities up to his mid-shins. And also looking at his skins, you notice scattered bruising on the flexor surfaces of his forearms bilaterally. And of note, his auscultation exam on his chest doesn't necessarily reveal any murmurs, no rubs, and regular rate and rhythm is also noted. So going to the ECG, because that's what we do when people come into the Cardiac Direct Access Unit.
One more question, Gabe.
Absolutely.
Did anyone notice any bruising around his eyes by any chance?
I did not notice that when I first saw this gentleman.
Interesting. All right.
Since you have introduced yourself, Mike, why don't you take us through the ECG as well?
All right, my pleasure. So he looks to be in sinus rhythm. He's got upright P waves and leads 2-3 AVF, V5 and V6. He's got about a normal PR interval and a heart rate of a little bit less than 100 beats, about 100 beats per minute. Other notable findings are he has decreased voltages in the limb leads, and not so meeting criteria, obviously, looking at his precordial leads, has decent voltages in V3, V4. He does not have much of a R wave in V2, which you'd expect in a normal ECG. So in the appropriate clinical context, that could represent a prior septal anterior MI. But we're going to have to get more information to see if that's true.
And more information we actually got. So happy to be joined by Dr. Fresh today, who is actually going to walk us through his echo that was that we got right after meeting him in the direct access unit. So Dr. Fresh, why don't you walk us through kind of what your initial approach is to these images and give us some pointers about what we're looking at here.
Sure. So we are looking at a traditional parasternal long axis view where we can see the left ventricle, the right ventricle, the left ventricular outflow tract and the aortic valve and a little bit of the aorta. And then we can see the left ventricle, the mitral valve, and then the left atrium. So my you can do a lot with the parasternal long axis view. Like just getting this initial view when you're seeing a patient in a cardiac, like direct access type unit where you're trying to figure out acutely what's going on with him, tells you a lot of information. So it can tell us about, chamber dimensions, wall thickness, general assessment of function, valve disease, if we put some Doppler or color on, and even, the pericardium and structures external to the heart. So when you first look at this one, you notice like right off the bat that the walls of the left ventricle do not look normal. They are quite thick, and it really looks symmetric. Both the anterior septum that we're looking at and the infralateral wall both appear to be at least moderately thick. Also, you do see that the walls look a little bit speckly, or sometimes called like ground glassy appearance. It's a pretty subjective description, and it means sort of increased myocardial echogenicity, so brightness, but this is not really sensitive or specific as a finding, but it's often, you'll hear people throw that out in cardiac amyloidosis. So it kind of like heightens your curiosity about it and sort of wanting to know more and get some more information, but so I'll say that right off the bat. And then the other thing to note from this slide is that his overall function of the left ventricle doesn't look normal. It looks like it's going to be, when we look at some other views, slightly depressed. So here we've got measurements now. So as I mentioned, the walls look thick and they look symmetric, and you can see that the septum measured 1.6 and the infralateral wall measures 1.8, and this would be consistent with moderate symmetric left ventricular hypertrophy. Just for a point of reference, normal is around 1 centimeter or less. So again, this is in that moderate range. So now we're looking at a parasternal short axis. So essentially we're like bread lobing down the left ventricle. And this is at the base of the heart. So we can see the mitral valve coming in. So we're looking at the basal segments. And I think the most pertinent takeaway from this is it sort of confirms that symmetric hypertrophy. And it also shows us again that, lower than normal function, and looks like the walls are really not thickening appropriately, but it looks very global. I know we had seen that EKG, or sort of, is there an anterior septal infarct? And I'd say that just for the first two images we've seen, it looks really that it's more of a global functional decline. The other thing you should note there is you kind of see just a little tiny little pericardial effusion coming in and out.
How about this view?
So this is the one you probably are most familiar with in residency. This is the apical four-chamber view. So on the left side of your screen, you're looking at the right side of the heart, so the right-sided chambers, and on the left side, you're looking at the left-sided chambers, so the left ventricle and the left atrium. And again, here we see that lower than normal global systolic function. And what we do in the echo lab is we do that more quantitatively, and we'll get an assessment of the LV ejection fraction. And in this particular patient, 3D assessment was used, and I think they got 47%. So normal, again, is like 55% and above. Low normal is like 55 to 55%. And this is 47%. So again, it's lower than normal. And then also what we notice here is that the right ventricle, we don't see the free wall of the right ventricle very well, but we're kind of suspicious that it's not quite normal either. And it might look a little big as well. And then the atria that we see, just on first impression, look like they might come out to be a little bit big. I think they were sort of borderline when the direct measurements were made for the volumes and the dimensions, but they do look slightly big. And what that kind of heightens your concern for is, now we've seen like lower than normal function. We've seen this symmetric thickening. We've seen this sort of brightness kind of come out. And I'm already like, my ears are kind of up, like I'm looking for infiltrative cardiomyopathies. Maybe at this point, even when I'm reading the echo, I've like gone back to look at that EKG or looked at the patient's blood pressure, which we get on our reports from the sonographer. And if the blood pressure was normal and the EKG doesn't look like there's a lot of left ventricular hypertrophy characteristics that we see in hypertension, I'm already kind of looking for more information of other possible infiltrative processes.
And Coco, there was no sign of any aortic stenosis either to suggest that this ventricle has been pushing against some high resistance for a long time, right?
And that's a really good point. We saw that aortic valve on the first that first parasternal long axis, and it was opening really well. It wasn't very thick. We would do there are a lot more echo images that we don't have time to go through tonight, but no, it didn't look like any suggestion of aortic stenosis.
I see. And then, do you mind taking us through this? I feel like I always hear people mentioning or talking about diastolic function, but I know it's a big can of worms. But can you give us kind of the basic approach here?
Sure. Yeah, sure. Yeah, so you're right. Diastology, we could just talk about diastology for like hours and hours, just like introducing the topic. But so I think you're right. I think it's pertinent just to understand sort of what we're looking at here and what that helps us start to think about. So this is a Doppler showing transmitral velocities. And just so briefly, we see an E wave and an A wave. And the E wave is the first, yeah, thank you for pointing that out. It says number 2 right now, but that's the first one I'm mentioning. So the E wave, it reflects the left atrium to left ventricular pressure gradient during early diastole. So if you take that where you just had your pointer and like bring it all the way down to the EKG,
whoops.
You bring it all the way down to the EKG, and you can correlate that with early diastole. And then the next wave you're looking at is the A wave, and the A wave reflects the left atrial to left ventricular pressure gradient during late diastole. So again, you're like right after the P wave there. And that is affected by left ventricular compliance and contractile function. And the E wave is affected by rates of relaxation, left atrial pressure. And those two things in itself can give us a ton of information about diastolic function in the heart. And so we use this ratio. So here you can see the E to A ratio is close to 1.7. And so just looking at an E to A pattern like this, you normally, in a normal pattern, you would see an E wave that is greater than your A wave. But sometimes it can be pseudo-normal. And when that happens, and when the E wave is particularly high, you start to think about what does that mean, or what does that pattern tell you about the filling patterns, the relaxation, and is it possible that it's a restrictive filling? So the true, like, what we say, like the cutoff for restrictive filling for an E to A wave is 2. So it's not quite there, but it's getting kind of close. And then we also look at something called the deceleration time, which is the slope essentially of that E wave. So here that slope is 114 milliseconds. You can see listed up there, and that's a pretty steep slope, and less than 150. And that also is concerning for potentially a restrictive filling pattern. So what I want you to take away from this is that this can help us again decide sort of the degree of diastolic dysfunction in the heart. For the patient with already an abnormal left ventricular function, we know they likely have some diastolic dysfunction too. And in this particular case, we're in right now, if we were kind of charting it out on an algorithm, we're in this sort of pseudo-normal pattern, but having some features of potentially some restrictive filling. And since we haven't really said a lot out loud, but we're all kind of like thinking, I have a feeling where we're thinking about infiltrative cardiomyopathies. We're thinking that possibly amyloidosis could be on our differential. And in amyloidosis, you can have any type of diastolic filling pattern. In sort of earlier amyloidosis, you can have more of like a grade 1, we call it. And then the restrictive patterns can come later in the disease process. And so this is again kind of concerning that we're seeing some features of restrictive physiology. And this E to A gives us a lot of information.
I see. And then another image that is somewhat familiar to me on rounds, but still struggle with interpreting. Do you mind walking us through this briefly?
Sure. So this is a pulsed wave tissue Doppler, and it's of the mitral annulus. These are velocities across the, first on top across the lateral mitral annulus, and then the on below is the septal. And the big takeaway from this is that they're both low. This is, again, they're pulse wave tissue velocities, and these are also in early diastole, and that we call them E primes. And for the lateral wall, normal is around 10 or 0.1 in this case, and the septum is then the normal is more closer to 0.07. So these are both low, and since we were talking about amyloidosis, these can be really markedly reduced in amyloidosis, sometimes even like 0.03, 0.04. And actually, you could even see this sometimes even before you see really thick walls. So this is something that we look for when we're concerned about restrictive cardiomyopathies as well as infiltrative process.
I see. Awesome. Thank you. And I think this might be the last video we have here.
So we get a better, before we weren't on that apical 4 chamber, we didn't really get to see that right ventricular free wall.
Right.
So on the top, so the top, we were just sort of pointing to on the top portion, that's the right ventricle, and that does look thick. And again, it looks like perhaps the right ventricle is low normal or slightly depressed. And again, those atria look big just on my subjective interpretation, and you can still see the little bit of an effusion. So the one thing I say about unexplained right ventricular thickening and systolic dysfunction can be in the setting of really thick LV walls, can be a kind of clue for amyloidosis, and so and it also can be a poor prognostic sign too.
And I think the last actual image we have is this one, and I think this might be our money slide here. Do you mind talking us through what's going on here?
Of course, and I'm glad you call this the money side, because we call this the bullseye for global longitudinal strain. And we also include this report because, as I said, I've kind of been working up to this the whole time, that we've been concerned about infiltrative processes. If we knew this patient didn't have a significant history of uncontrolled or bad hypertension. And so when we do this this is called global longitudinal strain, and this is abnormal. So abnormal it's kind of hard to wrap your head around, but a normal global longitudinal strain, and this is longitudinal, like left ventricular contraction, is less than -18. So negative numbers less than 18. So anything more positive than that is abnormal. And so this is again -9 on average globally. And then what you can see here is that essentially, so global longitudinal strain in cardiac amyloidosis is often reduced, and even when the left ventricular function is normal. And then what we see here is that you're looking at a bullseye. So the center of the bullseye is the apex.
I see.
It sort of, you see how it's already kind of labeled for you? You can see this sort of kind of looks like our short axis view that we were looking, but it's kind of mapped on each other. And we're looking at all the different portions or regions of the heart. And at the very outer edges is the base. And then as you move towards the bullseye, that's the apex. And as I told you, -18 is normal. And so what we see, and there's a very pattern that is pretty sensitive and specific for cardiac amyloidosis. I believe it's in the 90% for sensitive and in the 80% for specific for cardiac amyloidosis.
Wow.
Have sparing of that apex. So the basal segments are affected sort of worse of the cardiac function or contractility than the apex does.
Wow, Coco, thank you so much for walking us through that. I definitely could have not done that by myself, and I think this actually informs a lot of what we'll be doing next for our patient. And it sounds like cardiac amyloidosis has been kind of climbing up on our differential ever since that first image. And so I actually want to take some time to talk about how that actually fits in restrictive cardiomyopathies, because I think you mentioned, yes, this seems like more and more suspicious, but I think it's also important to know, how cardiac amyloid itself is related to its other cousins of restrictive cardiomyopathy, and especially how it fits with our patient here. So, restrictive cardiomyopathies, I like this picture because it breaks it down into 4 buckets. And these buckets include many different diagnoses that I'm about to show you guys. But I think, it can be a little scary. So, for example, this to me looks tough. But if we go through it systematically, you'll see it's actually not too bad. So going from the left, talking about inflammatory reasons of why someone would present with a restrictive cardiomyopathy, our patient here, low-hanging fruit, he's had no history of radiation therapy to his chest, no eosinophils, no sort of long-standing allergies, and no real reason for us to think that he would have either lobular cardiomyopathy or post-irradiation cardiomyopathy at this point. And even when we talk about endomyocardial fibrosis, usually, from our understanding, shows to be primarily in tropical regions, subtropical zones as well, and presents at a pretty young age, and is the most common form, fun fact, of restrictive cardiomyopathies worldwide, turns out. Our patient doesn't necessarily fit any of those criteria very, very well. So we can actually bring down inflammatory causes of restrictive cardiomyopathies a little bit lower in differential. This is a little more pertinent, the next bucket, which is hypertrophic. And I think Coco mentioned some things as far as, this doesn't necessarily give us impression that this the reason why he's so his ventricles are so big is due to a hypertensive cause. Again, he has no history of hypertension, and along with that, we didn't see any sort of aortic stenosis on his echo to let us know that this poor ventricle has been pushing against some high resistance, and the right ventricle was also thick, which goes against more so a left-sided strain on that heart. Again, he has no family history of HOCM or of any sort, really. And the other bucket I'll talk about is a primary/idiopathic bucket, in which we know he doesn't have diabetes, but if we're going to start going down the idiopathic route, I think it'll be wise to maybe focus on the other branch of this diagram and talk about deposition diseases here. So as far as deposition diseases, looking at storage. So again, this is, I didn't mention this, but his iron panel was actually pretty normal without any thought or reason to think he's got iron overload or hemochromatosis. Fabry disease, from my understanding, it sounds like, this most commonly has reduced strain in the basal infralateral region. Our patient's strain imaging actually shows apical sparing instead of what we would normally see in Fabry disease. And so I'm going to put it down on differential for right now. Glycogen storage diseases, my understanding, those also present pretty early on in life. And so I think overall suspicion for storage diseases is pretty low in this gentleman. And so that brings us to infiltrative diseases. When we think about sarcoidosis and its infiltration in the heart, I usually think about patchy infiltration, not necessarily something I'm seeing here as far as a diffuse infiltration of the heart that we do see on our echo. Along with that, a lot of those patients could present not so much with low voltage everywhere, but mostly AV blocks or different conduction diseases that we're not necessarily seeing right off the bat. So we can probably put sarcoidosis a little bit lower in the differential and actually focus on what we've been wanting to focus on this entire time, which is amyloid. Just to summarize, again, we have the 63-year-old man with no history of hypertension, now presents with volume overload in the setting of low limb lead voltages in his ECG and a TTE showing symmetric LV hypertrophy, reduced global longitudinal strain with apical sparing. So I think that the thought on everyone's mind is, okay, so what do we do next? What is the next step to really continue validating whether this actually is cardiac amyloid? And before we actually go into it, I do want to bring in Dr. Pablo Quintero to talk to us a little bit about the pathophys behind amyloid, because that's really going to inform where we go next with our testing here. So I'm going to leave the answer to this question for a little bit later. Dr. Quintero, do you mind walking us through how amyloid even affects the heart to begin with?
Yeah, sure, Gabe. Thank you for inviting us tonight.
Of course.
Yes. So you went through a lot of detail how to work this kind of cardiomyopathy in somebody who has heart failure, thick walls, absence of hypertension, and low voltages in EKG, which is basically a clue for something is replacing the walls of the heart that really is not electrically active. That's why is that discrepancy that you just brought that into the picture. The true LV hypertrophy is really made of muscle that gets thicker and thicker, and that conducts electricity. However, the thickening of those walls that Coco was describing, it's really what we're seeing is the deposition, abnormal deposition of a substance inside the fibers or between the fibers of the myocardium and replacing those fibers. So that's where the discrepancy between the wall thickness by echo and the electrocardiogram. That doesn't always happen, and it's, you can have to see it in 50% of patients. So not having low voltages is not going to rule out cardiac amyloidosis. So that's something that is important for us to keep in mind.
And Pablo, where could these fibers be coming from?
Yeah, no, that's a great question. So it many different substances could ended up in the heart. So when you think about the big picture of cardiac amyloidosis, I tend to put mainly 2 to 3 buckets. So one of them is when blood cells decide to make an abnormal substance at high concentrations, which you have that in item A, AL amyloidosis. So it's an overproduction of light chains that the plasma cells start doing. They have certain affinity for the heart. In fact, they directly are toxic for the heart. If you take those, so maybe plasma from a patient and put it in cardiomyocytes, you will see that actually that decreases contraction for those cardiomyocytes. So it's somewhat toxic, those AL light chains. And then the other big bucket is an abnormal deposition of a substance that our body normally has, and the transthyretin amyloidosis, which has 2 main flavors. In one of those flavors, some patients have a mutation. It's a genetic mutation that makes that the transthyretin tetramers make it unstable, and then they break down. And because they are unstable and they break in dimers, those dimers go and deposit in many different organs. It's not only the heart. Some people have a mutation that allows that to happen. Some others, it's just the classic wild type, which is our normal protein that ends up being misfold and break down and deposited in many organs. But just by looking at the echo, you can tell.
It sounds like AL amyloid and ATTR, the wild type, are really the most common kinds that we'll be encountering, especially in warts residents. And when we're thinking about cardiac amyloid under differential, what are some of the characteristics that can differentiate between the two, at least from a clinical perspective initially?
Yeah, so you have these 2 main buckets there. The AL amyloidosis tends to be in a younger population compared to the ATTR wild type. It used to be called senile amyloidosis. So, it's an older population. There is some gender preference for some of this. It's not totally, you won't base it on this. The organ involvement, certainly AL is going to affect many different organs. These proteins can deposit in the GI tract, in the liver, in the heart, in the nerves. Actually, both of them can have sort of affect the nerves deposition. So neuropathy is something that happens. ATTR wild type, yes, affects the heart a lot. And there is a couple of clinical pearls that it's useful from the involvement perspective. So bilateral carpal tunnel, for example, you should be thinking about this, because it could be a very, very early manifestation before cardiac manifestations.
Interesting.
Spinal stenosis or rupture of the biceps. So that is abnormal. And in some centers, for every carpal tunnel release surgery that they do, they send this to pathology and look it under the microscope and make sure that there is no amyloid deposition there.
Wow.
So just think about that. The EKG, as we said, yeah, both of them can have loading voltages, but it doesn't rule it out. And the transthoracic is definitely not going to help you to differentiate between these two.
I see. So maybe it sounds like we might have to get some other labs involved and maybe some imaging to be able to differentiate them more clearly, huh?
Yes. So definitely the treatment is going to be completely different, and you do want to you can miss the AL amyloid because when you think about prognosis, it's probably the one that has the worst prognosis of all of them. So making sure sending the urine, UPEP, SPEP, free light chains ratio is an important part of the equation with immunofixation. So that should help you to evaluate that. And then there are other testing that we can do, imaging-based, to look at the ATTR, for example. There is a bone scan that is easily available in many different centers, and we look at the uptake of the spirophosphorus scan within the heart, and it's pretty sensitive, and has a pretty good positive predictive value for that. And then cardiac MRI, it's a great imaging modality, but it won't help you differentiate between these two. And then you had the fat pad and cellular biopsy. I mean, the fat pad can be positive. It's highly to be positive up to like 70%, 60 to 70% in AL, with less in ATTR, but the percentage is lower. So those are the things you should be thinking always, aside from the blood work, the UPEP, SPEP, and serum-free light chains. And then along the way, you can send some imaging testing to help you out.
Awesome. So Dr. Quintero, it sounds like our next step is actually getting this free chain, since he was into CDAC and he was more than happy to give us some of his blood. That's actually what we went through first. So serum-free light chains is what we got with the sodium pyrophosphate scan, kind of in the talks as we were putting in our orders initially to work this gentleman up. So, you know, me not being a hematologist oncologist, know just enough to get myself familiar with free light chains, but I am so happy to be joined by a professional here, Dr. Shpilsky. Dr. Shpilsky, you have been immersed in the hem-onc world the last 2 years, and I would love your input in walking us through what the SPEP, the UPEP, this free light chains, what do all these mean and how they apply to the workup of our patient at this time?
Sure, Gabe. Thanks for having me.
Of course.
So the first thing that I think we got to think about pathophysiologically, just like we would in anything else, is what are we really looking for? What is it normally supposed to do, and what's gone wrong? So when we're talking about SPEP, UPEP, free light chain, we're looking at antibodies, immunoglobulins, those little Y-shaped things you see on the right side of your screen. They're made up of this Y, the longer part of the Y being more of the heavy chain and the shorter part being the light chain. And really, in a serum protein electrophoresis, we're going to be looking for all the proteins in the serum. In a urine, we're going to be looking for all the proteins in the urine, and then the light chains are just going to be those little short parts. Now, in a normal plasma cell, right, this is a mature B cell that's living, it's looking for an antigen to respond to. All these different plasma cells in your bone marrow and sometimes in your lymph nodes are looking for something to respond to, and they're making all kinds of different antibodies, right? IgG, IgM, all kinds of not just those varieties, but also just all different chains to see, hey, what can we respond to? What do we need to make more of? All right. So that's normally what plasma cells do, create a bunch of different antibodies, trying to find the one that fits the right antigen.
I see.
Normally, if you were just to run your serum, right, the blood that we take out and was separated in a serum top tube, a tiger top tube, you're going to run it just like you would, like a Western blot against an electric gradient. And these things are going to be divided out by their charge and their size. So the first thing that we have pretty much the most of protein-wise is albumin. And that's why you see on this SPEP, that's our biggest peak. After that, you get all kinds of different proteins that are in your blood. It's actually a smattering of proteins. And most immunoglobulins end up in that gamma region, which is all the way to the right. Okay. A fun or interesting side note is random things like beta-2 microglobulin, alpha-1 antitrypsin. They are just enzymes or proteins that we found that ran in that section of the gel.
So it has nothing to do with structure or beta-pleated sheet somewhere?
Exactly. So when you see like beta-2 microglobulin, that was just a microglobulin that ran when they just put blood through it, basically, you know, an electrophoresis, and ended up in that 2 peak.
Okay, so it sounds like I got a pretty good understanding of the SPEP now on normal function. So what happens when plasma cells go crazy, Jason?
All right, so I think it's a great way to put it. This cancer of the plasma cell, the programming has gone haywire, right? So typically, if a plasma cell finds its antigen, right, the right antibody matches to the right antigen, it expands and it wants to make more of that one thing. Now, what would happen if just a random cell got selected, right? A clone or a particular cell that was making whatever it wanted, some sort of antibody. It got selected without any real antigen trigger. Well, that cell just starts making one type of antibody, and that one type of antibody isn't really useful to anybody. And I like to think of it like somebody put a wrench, into the works. But typically this plasma cell, all it does is make one type of protein that's useless, and it just churns it out and over and over and over. And in the bone marrow, that one plasma cell is now expanding to an entire population of cells that just keep churning out this one useless antibody, this one useless protein. And so I think you could see with the color coordination here, the blue normal plasma cell made a wide rainbow of antibodies, and this bad or malignant plasma cell is only making this red-blue antibody.
I see. And so all these light chains now have the chance to be able to get in between our myocytes, sounds like, and potentially infiltrate there as well. And I guess it's not only myocytes, but really anything they can get their hands into, huh?
Well, that's the really interesting part about this, or one of the most interesting parts, is you are basically dumping all of these light chains, all of this protein into the blood and circulating everywhere. And in fact, it can deposit in really any organ and cause dysfunction.
And so, going back to the normal function of a plasma cell and what the normal SPEP looks like, I'm guessing the SPEP looks pretty different when we're talking about a malignant plasma cell. Is that right?
Yeah, and you can, as I mentioned before, right? So most of these antibodies, based on their size and charge, are ending up in the gamma region all the way at the end. And so if you just have a ton of that protein, perfect transition, you're going to see a M spike. The M is really not specific for doesn't stand for anything, but you really just see a spike of protein in that gamma region, right? It's way exceeding albumin, which is usually one of the most, prevalent proteins in the blood. And so here you are now with a tremendous amount of protein that's now dwarfing everything else. And you can see that that's way off than before.
I see. And the immunofixation down here, just briefly, looks like we're getting a lot of IgG and kappa, right? So that's kind of what the plasma cell is making. Great.
Yeah, it's the immunofixation lets us put a name on kind of the random proteins that we saw in the SPEP. And in this case, we can see that, okay, the program that got stuck on, right? The only antibody that this malignant plasma cell can make is of the IgG variety, okay? And it can either get stuck onto making just kappa or just lambda. And in this case, it looks like just kappa it got stuck on. And so many people would call this a IgG kappa restricted process.
Awesome. Thank you. And so this is an example patient. Jason, I actually want your help interpreting our patients' SPEP and free light chains that we were able to get.
Yeah, so this is where things I think get really interesting for us as hematologist oncologists, and for those of you that are budding to become that. We think of, right, so we start to see the immunofixation and of course the SPEP having an abnormal band. In this case, they're calling it IgG kappa, and that's what we see on immunofixation as well. And so we're starting to think, okay, we're in some sort of clone mode. Something is stuck, right? We just keep churning out the same thing over and over and over again. And that probably indicates some malignancy involving a plasma cell, right? And more commonly, when you order SPEP, UPEP, free light chains, you're thinking multiple myeloma. But closely related to it are these amyloidosis or light chain deposition diseases. And so if we kind of take this left to right, the first thing I'm looking at after, okay, I have a trace abnormal protein, right? Trace is unusual. I would sometimes expect to see more in somebody that's symptomatic, right? A clear big band as you would see in that example SPEP over there on the right. So it kind of puts me in that frame that says something is stuck here, something has gone wrong. We could then go to the free light chains, right? We have the free kappa, free lambda, and the ratio. The ratio is really, really important, and that's where I get a lot of consults.
I see.
A lot of times, you think about it as like a 2-to-1 normal ratio,
Right.
kappa to lambda. Sometimes in kidney disease, it gets a little skewed. Once we're starting to talk into the double digits, it's another red flag that this is something that's stuck making the same protein over and over, and it's really just making mostly kappa. What's interesting is on this one, you can actually see in the light chains that they had to dilute the kappa 1 in 100. So multiply that number by 100, and that's actually how much light chain there is. So the kappa lambda ratio is even more skewed in the kappa direction, right? It's kappa restricted. And that all of a sudden, right, we're really thinking about a malignant process. The kind of the last part, we have the IgG, IgA, IgM. We could see that they're reduced, which is something you see when you start affecting plasma cells. Immunoparesis, you keep churning out a useless antibody. It actually crowds out other good antibodies, and a lot of these folks are immunosuppressed. They're functionally immunosuppressed. So just to take this all together, we see an abnormal protein that looks to be restricted by making kappa light chains. The heavy chain part, right, the serum part of this actually is trace, and that's a little bit unusual. So what we have here is a process that looks to be churning out light chains, but not really making a lot of heavy chain or full antibody. And that's something that is more characteristic with AL amyloidosis and less so with myeloma, where you'll typically see, you know, grams of protein on the S.
Interesting. Wow. And when Dr. Quintero, when you're looking at all these labs too, you know, what are some of the things that you're thinking about as far as, you know, how to counsel this patient or kind of where to go from here? And Jason, please feel free to step in as well.
Yeah. So this is why the approach for these kind of patients needs to be multidisciplinary, because once I get these kind of results, I just have to speed dial Dr. Splisky and say, hey, we have a problem here, because certainly we have a pretty abnormal blood test and with a very abnormal echocardiogram, and we need to clinch the diagnosis, and then we need to figure out how. There are, you know, you talk about previously, is there any other modality to address the cardiac? How can I prove that this abnormal blood test is really causing the wall thickness in the heart? Right. So there are other, you know, if you use cardiac MRI, you can actually look a little bit more into detail, for example, about how the wall looks like. And it's an other clue to sort of push to say, this is probably cardiac amyloidosis. And it sounds like it's an AL amyloidosis. And I basically have a conversation with the HemOnc team and what's the next step to evaluate this, because I think, Jason, there are other things that you need to figure it out, right? If with this abnormal, you talk about that spectrum of clonal disease. So
yeah, it's a great point, you know. So there is a lot of overlap in these diseases. But what our SPEP, you know, our free light chains are really telling us is that something has gone wrong with our plasma cells. And really to investigate that further, we have to go to where the plasma cells generally live, and that's going to be in the bone marrow, right? And via bone marrow biopsy, we're going to be able to start to identify a little bit more about what's going on and where in this spectrum of disease are we, and how much overlap is there between something that's maybe more looking like just AL amyloidosis, how much of it is looking like multiple myeloma, and how much overlap is there. Additionally, we'll be able to get, you know, molecular profiling and sort of the more esoteric details that might push us towards one diagnosis more so than another. And at the end of the day, all of this is to help guide treatment.
Jason, one of the things that you mentioned that was pretty interesting when you were explaining these patient labs is that trace abnormal in the UPET. So could we have missed this if we didn't order the free kappa lambda ratio? Is that why, sometimes we only order the SPAP and forget to order the other one? Could we miss it?
Yeah, I think that it's pretty commonly, I think that SPEP, UPEP is like the bread and butter. I think it's probably still in like the step 1 textbooks. With like, obviously heightened lab testing, the ability to really identify light chains in the serum, it was a huge step forward in the diagnosis of these conditions. If you have something that's creating the full antibody, a plasma cell that's making the full antibody, that's typically going to show up in the serum, and it may show up in the urine. If you have something that is predominantly making light chains, that is not necessarily going to show up in the serum, in the blood, because it's being excreted predominantly by the kidneys. And so the UPEP adds another layer of sensitivity. But even that, you can see in this where it says, oh, it actually doesn't look like there's a lot, a trace abnormal UPEP. Looking at the free kappa lambda light chains, you can obviously identify that there's something more significant going on.
I see. So thank you guys. That was an incredible discussion. From all of that, I've gained that, first of all, it sounds like the free light chains are definitely worrisome. It doesn't give us I guess a slam dunk for any sort of malignancy, but it definitely makes us want to explore this a lot further. And as Dr. Quintero pointed out, we're still not sure exactly, or we can't necessarily say with 100% certainty that what is that gunk in between those myocytes is actually amyloid, most likely. But I think there are some tests that we can get next in order to really, really reassure us. Jason, you talked about the bone marrow biopsy. That will be a next big step from the hemonc perspective. And it sounds like to further investigate his actual chance of cardiac amyloidosis, it might be imaging that we'll be getting next. And as I showed in the slide previously, that imaging would be a sodium pyrophosphate scan. And with that, I want to leave you guys with some learning points of what we've been able to talk about today. The first one being that, guys, when you see low voltages with a diffusely thick ventricular walls, along with that low global longitudinal strain with apical sparing, just as Coco said, it should increase your suspicion for cardiac amyloid. Next, the most common types that we reviewed were AL amyloid. So again, a plasma cell dyscrasia, and a wild type ATTR, which, as Dr. Quintero said, we usually see that at the older ages. And for our patient, not necessarily the case, but again, something to keep in mind as far as the most common types. Now, when we're talking about amyloid deposition, Dr. Quintero also said this directly injures myocytes. And when we walk through the pathophys, it impairs contractility, as we saw in the echo, and also leads to diastolic dysfunction that Coco was able to point out for us. And then lastly, from what we just talked about, getting the SPEP, the UPEP, and the serum-free light chains really increases sort of sensitivity for picking up something that might be going on with the plasma cells themselves. And is sensitive and definitely a key in the initial workup of suspicion for really any amyloid, but specifically AL amyloid. And to find out the answer to what his imaging will be like, we're actually going to post a tutorial. So you can definitely follow us on Twitter, handle to come. But as you know, the sodium pyrophosphate scan is has incredibly high positive predictive value for ATTR amyloid. Thank you so much, Dr. Spilsky, Dr. Quintero, and Dr. Fresh for joining us today. We thank you, the viewer, that you could be literally doing anything else, but you decided to hang out with us and learn some more about cardiology and hematology oncology today. So follow us at the ZollCenter on Twitter, and please keep the lookout for that tutorial about cardiac imaging and cardiac amyloidosis. Thank you guys so much, and have a great night.